Good morning, everybody. We are today talking about weight gain and weight loss, as well as peripheral edema, which are sort of semi-unlinked, but as we always do, we're just following the chapters in Edinger. Weight gain and weight loss I found very underwhelming in the chapters, so we're going to leave those till last because peripheral edema is a much more interesting thing to talk about just from a physiology perspective, and also more of a kind of clinical perspective. I found it much more interesting. Is everyone all right with that?
Yes.
Yes. Yep. Good. And now I'll hand over to Josh to run them. Just kidding. I do not want him.
Just organised this week.
Next fortnight. You do the next one. So peripheral edema. Let's talk about what is peripheral edema?
Increased fluid in the interstitial space.
Excellent. What is an interstitium?
It's the space between, like, outside of cells, but in between the vasculature and cells.
Mm-hmm. And what's it made up of?
Mostly fluid, isn't it? And like fibrous, like all connective tissue.
It's, yeah, essentially connective tissue. So it's actually pretty tight. Like there's not a lot of free space in there. There's usually not a lot of fluid in there. So that sort of tightness in the interstitial space, like the sort of space between, you know, vessels, organs, structures, is not, it should be kind of compressed, right? Because what happens when you've got dead space in a patient, like post-op or something like that?
It fills with fluid, doesn't it? Yeah.
Exactly, yeah. So you want the interstitial space to be quite tense, and in health, it's quite tense. And that's one of the factors that keeps fluid in the vessels rather than leaking out into this kind of pressure, sort of down a pressure gradient into the interstitial space. Does that make sense?
Yeah, I never thought of it like that, actually.
Yeah, it's an interesting perspective because we always think about the forces inside the vessels, but not the force outside the vessels, which actually maintain that. Particularly once you get down to the capillary and venule sort of end, like these are kind of these tiny little vessels like these, they're very porous. What keeps the blood in the circulation and stops it from just pooling around, and it's that pressure from the outside. So that's a good segue. What keeps the blood in the vessels apart from interstitial pressure?
Oncotic pressure.
Good. Excellent. So we can look at that plasma oncotic pressure and interstitial oncotic pressure. Which one needs to be higher to keep the blood in the vessels?
Plasma oncotic pressure.
Plasma oncotic pressure, exactly. So fluid wants to move towards the oncotic pressure. So if you've got increased oncotic pressure in your plasma relative to your interstitium, then the fluid's going to have net movement towards that interstitial at the intravascular space. Sorry if I get my words wrong. I just realized I was saying things backwards. Please pull me up if you need to clarify anything. So we've got oncotic pressure. We've got the pressure on the outside of the vessels by the interstitium. What else? What other factors?
Osmotic.
Sorry?
Osmotic. I don't know if you call it pressure.
That is an interesting point. Is osmotic pressure a combination of both oncotic and hydrostatic? It's actually the pressure that dictates diffusion as a whole rather than
creating the gradient with whatever.
Yeah, so I guess another way, the question I've asked is what keeps the blood or fluid in the vessel, and another way to ask that might be what dictates osmotic pressure. So what dictates
so your electrolytes, the charge,
osmolality,
osmolality, tight junctions,
the
the
Good.
And
So-
electrical charge on the endothelium.
Good.
cell.
Yeah, perfect. Excellent. So the big one that jumped out there, so we've talked a little bit about oncotic pressure, which is one of those things that dictates both charge and osmolality. And then you mentioned the vascular permeability, the tight junctions. So what might impact vascular permeability?
Inflammation.
Oh, sorry, two people at once.
We
and then-
both said the same thing. Inflammation would be one.
Inflammation, yeah, so that's the biggest one for sure. What condition is not, if you took a histopath of a blood vessel, you would find no inflammation, but there's profound alteration in permeability, vascular permeability. It's an acute presentation usually.
Like trauma, some sort of trauma to the vessel, but that would
Ah.
cause inflammation.
We usually cause it, yeah, some inflammation there. It's a form of shock.
Allergic reaction?
Yes.
No, that'd be, oh, really? Okay.
Yeah, so anaphylaxis will alter vascular permeability quite dramatically without necessarily being an inflammation mediated response. So you covered the three that I wanted to get to. So have we? Yeah, we've covered increased vascular permeability. We've covered oncotic pressure. We've covered. Did we do hydrostatic pressure? Is that what you're going to say? So what is hydrostatic pressure?
The fluid pressure.
Yeah.
Well, in the arteries, it's from the heart. In the veins, it's like the resistance of the veins to flow affects it. But the other very important one is the lymph system, because it's got an enormous capacity to drain fluid.
Absolutely.
So
Good.
I think in my experience, one of the major causes of peripheral edema is lymphatic obstruction.
Yes.
Which is usually carcinogenic.
Yeah. Completely agree. So they're the four. So oncotic pressure, hydrostatic pressure, decreased lymphatic drainage, and increased vascular permeability. So if you've got edema, it's really nice to have that checklist in your head and say, okay, what mechanisms could this be? So if I've got, let's talk about different ways that edema might accumulate. And I'm going to actually include effusions into this, even though it's not really part of that chapter, just because it's often similar mechanisms. So if I had ascites, what would be the most common cause of ascites or modified transudate in the abdomen? What mechanism of edema?
Probably increased hydrostatic pressure. I'd say.
Good. Because what disease is that most commonly linked to?
So things like right-sided heart failure and neoplasia is often the case.
Yeah. And probably liver disease as well, increased portal hypertension. So most of the time, if you've got an abdominal effusion and you've done your fluid analysis and it's a modified transudate, it's going to be an increased hydrostatic pressure problem.
Yeah, so pericardial effusion, or more rarely pericardial neoplasia with a stiff right ventricle. Diastolic function's not going so well. Or heartworm disease can do it too, apparently.
Yeah, it's interesting. We don't see that very often. That's a good one to put on the radar. In fact, I've never seen heartworm. I've seen dogs test positive, but I've never seen a dog clinical for heartworm disease. Is anybody else?
Oh, yeah.
Oh, yeah. Did you pull out the worms through the jugular?
No, I'm not a surgeon.
No.
I treated them medically, and I had an unacceptably high death rate, I thought. But I noticed the protocols for treatment now are a bit different. You give one dose and and then a bit later another dose, and then I think a double dose later on. And rest them. But I could never work out what I was doing wrong. And the vet working for me at the time said, well, actually, you're treating them better than most people do.
Yeah.
So I think it was probably just the lack of
Terrible disease.
just luck
Yeah.
or bad luck.
There's some really cool videos on techniques for removing heartworms via the jugular. Has anyone seen them? Yeah. So it looks like the people pass a catheter with like a split in it down the jugular, and then they twist it like spaghetti on a fork and they pull out ones. It's so cool to watch. I want to see it. Sure. Beg your pardon, Josh.
So gross.
It's so gross. I would, and it's preferable for the patient to remove those worms because then the risk of embolism into the lungs is so much lower. So it is better for the dogs to do. So that's why I want to see it. I can justify wanting to see it, but it feels like it would be a very satisfying activity if you got them. So I think Jeff raises a good point. If we're talking about congestion and increased hydrostatic pressure in the abdomen, it can be anything from the heart, and that might be like tricuspid dysplasia, it might be pericarditis and restrictive heart disease, it might be pericardial effusion, it might be a tumor in the cava that goes between the right side of the heart down to through the liver, or it might be liver disease, which is obstructing the portal, causing increased portal hydrostatic pressure. So it could be either caval or portal systems that are congested there.
I had an idea that I just can't think of the name of it now, where the central lymphatic vessel that runs into the precava, if that's obstructed, can that also cause it? That'd be and high pressure in the precava could do that, or or neoplasia somewhere along the line.
Yeah, so we typically would see, so the thoracic duct is the major lymphatic vessel that dumps into the cava. We see in cats chylothorax associated with right-sided congestion, in fact, bilateral congestion, more commonly in cats. And we see chyle building up. So we've got a more lymphatic component to the fluid that's accumulating, but we virtually never see chylothorax in the abdomen. So if we did see a chylothorax, does everybody see where I went wrong there? Never
If we saw chylothorax in the abdomen, we'd have to relearn our anatomy.
It's definitely a diaphragmatic hernia.
I didn't realize it until way too late there.
Oh, that's funny. So chylous effusion is what I'm trying to say in the abdomen. It's often, is it? I don't know if I've ever seen a chylous effusion in the abdomen.
We had one last week that looked chylous, but it came highly neoplastic, you know.
Okay, so it's very similar.
But it physically looked chylous, but it obviously highly cellular, I guess.
Yeah.
Yeah.
That'd be something bad, right?
Yeah. Horrible.
It was a middle-aged dog.
Oh, shame. So in theory, like something like lymphangiosarcoma, which was causing lymphatic obstruction in the abdomen, could cause a chylous effusion. But more often when we've got lymphatic congestion in dogs, I think we see protein losing enteropathy, or it's associated with like lymphangiectasia and dilated lymphatic vessels in the gut. And we don't actually see an effusion developing as such. We see it leaking into the gut. Whereas we definitely see lymphatic congestion causing a chylothorax in the thorax, but not so much in the abdomen. But I don't really know what the mechanism of that is. So lymphatic obstruction is one of our differentials for an abdominal effusion, but it would be a chylous effusion rather than modified transidate. So what's another potential cause of mechanism of modified transidate or a pure transidate in the abdomen?
Decreased oncotic pressure is another big one.
Right.
Like you see them with PLEs sometimes.
Yep.
And they just have no albumin.
And how would that, if we're sort of trying to help make a prioritized differential list, how would that present differently to a dog with, for example, like right-sided congestive heart failure? Like, will there be anything else on your physical exam that helps you think, okay, this is probably a low oncotic pressure as opposed to a localized hydrostatic pressure?
You should have peripheral edema as well.
Good. Excellent. Yeah.
Very good.
Yeah. So when you're thinking about edema development, think localized or diffuse, because increased hydrostatic pressure and decreased lymphatic drainage can be localized. Increased vascular permeability can be localized, but decreased oncotic pressure can't.
Mm.
So if you've got diffuse peripheral edema, decreased oncotic pressure is right up there.
I was under the impression that decreased oncotic pressure can never solely be the cause of, like, you can just never have that much low albumin, like what the textbook says about 12, but that can never be the sole cause. You have to have other factors like hydrostatic pressure coming into. Is that not right?
To cause peripheral edema,
Mhm.
I think we definitely see it.
Okay.
Yeah, these are, and it may not be clinical because they've got to be really puffy before you detect it clinically. But if you're trying to put a catheter in, sometimes you just get a little bit of ooze when you're next to the vein. Like, there's too much fluid in the space next to the vein here. And that little kind of serous discharge around the catheter insertion site and stuff like that. So it might not be, pitting edema. I think pitting edema is associated usually with a combination of increased vascular permeability, usually with systemic inflammatory disease, and decreased oncotic pressure. But I think you definitely do see, with albumin of 12, they're puffy for sure. And typically the volume of ascites is lower in those cases. Is that your clinical experience, Josh?
With the
decreased oncotic pressure?
one, I remember seeing one with you actually, and its belly was so big we had to drain it a little bit. I thought, but that was like what Pooja's saying. Maybe there was two things going on there because it was a protein losing enteropathy case. It was very sick.
Yeah.
So I wonder if there was something else going on in the gut that was adding to that.
Yeah, for sure. And if we've got really profound inflammation in the bowel, we're going to have increased vascular permeability localized as well. Lymphangiectasia is the one kind of example of where I'd say you get really decreased oncotic pressure, but you get a localized edema or localized effusion. They get really profound abdominal effusions, which actually wax and wane. And often if you've got a primary lymphangiectasia dog, you ask the client, like, what have you noticed a change in kind of tummy circumference? The owners will say, oh yeah, it gets bigger and smaller all the time. And they get these waxing and waning effusions with not necessarily any GI symptoms. And their albumin's 15 and they've got this huge effusion. It doesn't really make sense. Why? That must be either lymphatic obstruction or increased hydrostatic pressure locally or increased vascular permeability locally. But how can we have such severe inflammation without them showing any clinical signs, really? It's it's an interesting disease. I don't really understand how that effusion comes and goes. And I haven't seen that. They talk about an effusion being present, but I haven't seen that sort of discussed as this is weird. Why does this happen? But I think it's weird, and let's start the discussion. Okay. What about if we've got a patient in hospital and we've got swelling in the forelimb that the catheter's in? What is the mechanism of that?
Probably increased permeability would be the one I'd be thinking.
From like phlebitis?
From inflammation.
Yep, could be.
So,
Sure.
like probably appropriate increased permeability.
Yeah.
What about that are not uncommon causes the catheter just becoming subcutaneous?
Oh, that is a good point. Yeah.
Yeah.
The tape.
Look for sparrows on the lawn before you look for canaries on the fence.
If it's distal to the tape, it's probably hydrostatic.
Yes, exactly. So it could be any of those mechanisms for sure. I think probably what we see most commonly is just a little bit more swelling in the catheter leg, just because we've got the tape on, we've got the bandage on, and we've got increased hydrostatic pressure and probably decreased lymphatic drainage if we're compressing around there. What about if we have a patient that presents with profoundly swollen right hind limb, which is hot to touch and has pitting edema. So when you push in on the swelling, it stays dimpled. And on ultrasound, we see a really profoundly enlarged right medial iliac lymph node that's compressing the visible vessels in that area. What mechanisms might we be dealing with there?
That'd be hydrostatic pressure as well, I think. Yeah, just because it's decreased venous return or venous drainage.
Yep. So it could be lymphatic or venous in terms of increased hydrostatic pressure or decreased drainage, for sure. What about the redness?
Mm.
I'd say we're probably.
Because there's secondary infection as well. I mean, I was thinking in terms of prostate or mammary cancer causing the lymph node enlargement, and that's probably one of the more common causes of this sort of thing. But it's pitting edema means it's a low protein edema.
Does it?
As far as I know, because like an inflammatory edema doesn't pit.
Doesn't it?
So the pitting edema suggests a vascular obstruction.
I'm going to challenge you on that. And we're going to talk, we're going to talk about, because the difference between pitting edema and non-pitting edema is it might help you clinically. And I went through this in Edinger last night, and I found it quite informative. So I'm going to go through that in a little bit more detail. But back to this case, when we're looking at a patient with a very enlarged lymph node, peripheral edema that's localized and associated with that lymph node, what is the mechanism of that lymph node enlargement? Jeff's mentioned potentially metastases or neoplastic processes in that lymph node. What other mechanisms of lymph node enlargement might we have?
Reactive.
Sorry, reactive.
Yes,
perfect. So what if this leg's red?
So it's
inflamed. Yeah. Could we be dealing with a local inflammatory process, which is increasing vascular permeability, causing reactive lymphadenomegaly, and then venous congestion secondary to that? And this is actually a situation I've seen once or twice, where there's been an insect bite or a localized cellulitis, which has presented as this huge peripheral edema that's localized and actually needed to be managed locally.
Yeah, wow.
Yeah. Okay, let's talk about pitting edema. So does anybody know non-pitting edema, is the fluid interstitial or not?
I presume it's not. No.
Yeah, it's not. Yeah. Exactly. So if you've got interstitial edema in that connective tissue, remember that connective tissue is trying to hold everything together. It's trying to have tone in it. So if you push the fluid out, it's going to hold tight together, and it's going to take a little bit of force for that fluid to creep back in. So it's going to stay depressed after you've pushed it. Whereas if you've got intracellular edema or cellular swelling, then it's going to be non-pitting.
Yeah, okay.
Yeah, so that's the difference. And it was a really nice, for me, a reminder for me reading that last night. So what mechanism would cause intracellular edema?
The only one I remember is, well, the other two things I think of when I see swelling is cellulitis, or myxedema.
Myxedema.
Hypothyroidism, but I've never seen that. I just know it's in my brain.
Yeah. Do you know what? You probably have seen it. If you look at classic one, like the golden retriever that comes in with like really low thyroid and their heart rate's like 60 and they're like, hey, when they walk in. They've got really thick lips and really thick ears. So there is a little bit of edema in these dogs. So now that you know to look for it, just have a feel whether you can actually cause pitting in there or not. And you won't be able to. It just feels so thick. And there's like, you know, they've got that kind of thick skin as well.
That's just a hypothyroid dog.
Hypothyroid dog. Yeah. I can't remember the mechanism. I'll ask Alex today of the thick skin, but I wouldn't be surprised if it is an intracellular swelling as well. The
Would
other
it be fluid overload when you asked about intracellular edema? Would that, like fluid overload, would that fall in that category?
good question. Chronically, yes, but what is the mechanism of edema development with volume overload?
I think it's interstitium. It comes to the interstitium. So
It will go to interstitial first. So you might end up with a combination of interstitial and intracellular swelling, but it will at one point in the spectrum be pitting edema.
Yeah.
So what's some of our mechanisms? Increased hydrostatic pressure, decreased lymphatic drainage, decreased oncotic pressure, and the other one, increased vascular permeability. Sorry. Which of those, if you've given too much fluid, which of those mechanisms is causing the edema?
pressure for sure, I think.
Yes, increased hydrostatic pressure. So you know the arterial system is not very compliant, so it's going to stay pretty stable volume the whole time. The venous system is very compliant, but it's going to get to a point where it just can't absorb anymore. So you're going to get increased hydrostatic pressure when you get to that point, and you're going to get congestion at that kind of venule level where the hydrostatic pressure in those venules, which would normally have fluid going from the interstitium into the vessels, is going to actually be going the other way. The other one that's mentioned as a non-pitting edema is post-surgery or traumatic swelling, which is interesting because I would have sort of said, oh, there's going to be interstitial swelling, but it's listed as an intracellular swelling with traumatic injury to sites, which I thought was a bit surprising.
Pitting.
Non-pitting.
Non-pitting, right.
Non-pitting, yeah, because it's intracellular rather than interstitial.
Good. That's good to know. Thanks.
Mm.
You learn most from making mistakes.
Hang on, which one? Pitting edema is due to increased intracellular edema.
No.
Interstitial.
Pitting is interstitial because you're pushing on that. It's like really fibrous and it's trying to maintain that tone. And then if you push the fluid out of it, it's going to hold the fluid out for just a second until it creeps back in again. So it's going to be pitting. Does anyone know what Starling's law is?
Starling's law of the heart.
Oh, no, I'm talking about Starling's law of osmosis.
Oh.
I went out for dinner last night and came home and was preparing for this after that. It's like 10 o'clock at night and I was like, oh my gosh. It's so complex, but it's essentially an equation that balances all the forces that we've been talking about and gives you what the actual tendency for fluid movement is. Is it like positive or negative sort of thing across a membrane? It's so unimportant clinically, but just
we've all forgotten it, I think.
and on it, like honestly, it put me into a little coma when I read it. It's the theory of this is like understanding fluid movement and what dictates like fluid staying in a vessel is very important clinically, but as soon as you apply maths to it, it becomes less relevant, I think. So I wouldn't worry about learning it, but it's probably, if you're sitting an exam, worth knowing that Starling's law applies to fluid movement in accordance with these 4 principles: increased hydrostatic pressure, decreased lymphatic drainage, increased vascular permeability, and the other one. I forget a different one each time.
That's interesting. I've always just looked at it as a balance of fluid pressures. You know, the forces in versus forces out, and whoever's the strongest wins, sort of thing. But
Yeah.
that depends on the permeability of the membrane as well.
It does, exactly. So there's those 4 factors to consider, and realistically, clinically, it's rarely one factor. It's like you've got IBD and low albumin plus inflammation, or you've got a insect bite and cellulitis plus lymphatic obstruction. So it's never quite as clear cut, but if you've got those mechanisms in your head, it does help you go, okay, I'm going to look at the heart before I look at doing gut biopsies, for example. Okay. Now, do we want to move on? Is everybody happy with edema, effusion, and effusions? Should we talk about other effusions while we're talking about fluid in places? What's the difference between a transudate and a modified, pure transudate and modified transudate?
Number of cells and protein.
Yeah, exactly. Yeah. So modified is just like the pathologist hedging their bets, sitting somewhere between inflammatory, neoplastic, or pure transudate. If you've got a pure transudate, you can go looking for kind of increased hydrostatic pressure causes. But if it's a modified transudate, there's just probably a little bit of increased vascular permeability in there, a little bit of inflammation in there as well. So what about if you've got an exudate? What might cause an exudate in the abdomen?
Well, it can be septic or sterile, can't it?
What's the most common cause of a sterile exudate in an abdomen?
Pancreatitis.
Very good. Excellent. Everyone says neoplasia, but it's pancreatitis. Yeah. And then neoplasia is probably the only other one that we see that degree of cellular accumulation. FIP could be one.
FIP?
Yeah. Could be for sure. Did you guys have a case recently, Jeff? Were you back at Hornsby Heights?
Yes.
Yeah. Was that one there? I think there was a cat with possible FIP.
Oh, I think I saw that one.
Oh, did you?
Yeah, ended up being a septic peritonitis. The one from Hornsby Heights. I saw it this week.
Ah, shame.
Fun, I think it was the name.
Yeah.
Really cute.
I missed last week because of the foot surgery, and also I was just crook. So.
Oh, shame. Yeah. So let's talk about septic exudates. What caused the septic exudate in that cat?
Bacterial infection.
From?
Don't know exactly, but some suspicion maybe it tracked in through the scrotal wound from castration, but it's like that must be so rare if that's the case. But I don't have any other good reason. But things like perforation of the gut is a big one, of course. Or migrating foreign bodies.
Most common, yeah, for sure.
But in this cat, we couldn't find anything, but that was the only real recent thing in the history that potentially could have led to it. But I don't know, like, have you guys ever seen that before? Like, how many cats do we castrate and leave the wound open and they're just fine?
Yeah,
I think anyway.
Never heard of it.
Been a while since I've done it, so.
I guess you get probably equivalent to an ascending umbilical infection in newborn.
Totally, yeah, like super rude.
And the other thing with cats is they can actually have septic peritonitis for such a long time before they tell you about it. They can get
so well.
Yes, they can get so sick. I remember having a cat in hospital and they kept declining ultrasound and stuff. And it had been sick for 6 weeks and it was just starting to kind of circle, need fluids, go off its food and stuff. But the owners had said, no, it's definitely been 6 weeks. It had a perforated duodenal ulcer.
Wow.
Yeah. And it was just like, oh, I'm all right.
We recently had a case where this specific cat, we did, so like the surgeon did biopsies for investigation of IBD sort of a thing. And 5 weeks post a routine biopsy, got septic peritonitis. This came in just unwell. It was a vet's cat. So she was obviously on the ball and she must have checked the temperature and temperature spiked to 40. So brought the cat in and then I did a focus and there was free fluid in the abdomen, tapped that and there was bacteria. But we couldn't, when the surgeons went in, they couldn't really find a perforation per se, but they did see one area of the jejunum which looked a bit sort of more red than others, but it was not a clear-cut perforation. So maybe a slight leak, like we just couldn't, but 5 weeks after a routine biopsy.
Weird. Because
So
that's
weird. Like, so
I
weird.
mean, the sutures have dissolved then.
Yeah.
That's I wonder how long that had been brewing for, because septic, like the peritoneum doesn't get a huge amount of blood flow. So you can have an infection brewing in there without actually getting a whole heap of pyrogens in circulation and stuff. And particularly if it's not a particularly pathogenic organism, like gram negatives will usually cause a fair bit of illness. But if it's a gram positive or something that's a little bit more low grade, or something that doesn't grow that well in that environment. So if you've got, I don't know, like an anaerobe or something like that, and it's not 100% anaerobic environment, it can brew for quite a while before they get a temperature and systemic signs of infection. And then often we put them on antibiotics post-biopsy. So we're killing off the bacteria that get into the bloodstream, and we're decreasing the growth of the bacteria, but we're not going to cure a septic peritonitis. So that bacteria is just probably hanging out there waiting for the antibiotics to finish, and then it can really set up shop. But yeah, cats do septic peritonitis very subtly. Dogs, it's more obvious. I think they tell you when they're sick.
Yeah, this particular cat is a Bengal, so couldn't normally touch. So that was a clue that something's quite wrong because you could touch this cat. But the Doppler was normal, this thing intensive. I got a Doppler of, I think from memory, it was 110, 120. So really didn't have that on my radar, because in the past, all the septic peritonitis that I've seen, they're crashing. They're like crashing and burning.
Yeah.
And this cat comes in, the only thing was I could touch it. So I was like, this is interesting. And then that's why I looked more, and then saw the flea. And it wasn't a large volume either. Like, it was a small volume.
Yeah.
Firstly, wasn't sure if I'll get it, but thank God, because if we had not got that volume, there's no way septic peritonitis was on the list. There was no way.
No, exactly. So I had a question from a clinician this week, and they'd done gut biopsies on Tuesday, and then Thursday the temperature spiked. She was like, "Is it septic peritonitis?" And I was like, what would the mechanism be if we're 2 days post-op? How would it be? Contamination during surgery or dehiscence, do you reckon?
Couldn't it be either or? Like, you should have both on your radar.
Yeah, I agree with both.
Yeah. So what is the range where we see dehiscence most commonly?
3 to 5 days.
Yeah, good. Yeah, can be, obviously can be up to 5 weeks.
In 5 weeks. Now I'm rechanging my...
But typically if you get to day 7, they're safe, I would say. I'm starting to get a bit confident at day 7. Yes, and the vet was sort of like, "Oh, it can't be septic peritonitis, it's too early." And I was like, "Oh, it could be." Let's do that abdomen. Okay. What other effusion should we talk about? Heme abdomen, that's boring. Chylus effusion in the abdomen, not chylothorax. We've kind of talked about already. Is there anything else?
I guess some other causes of like an exudative effusion would be things like like bile in the abdomen and stuff like that as well.
Good one. Yeah. So what is that going to look like cytologically? How, or even like, what is the fluid going to look like with bile peritonitis?
You get bilirubin in it, so yeah, it's quite high compared to blood, I think, is the thing you look at.
Yeah.
And the other one would be like uroabdomen as well.
Good, thank you. Yeah. So how would you, if you're in an emergency situation and you don't have a pathologist on hand, how are you going to differentiate uroabdomen from a modified transudate?
Check the creatinine of the peripheral effusion, and that should be like at least 2 times the peripheral.
Yeah, excellent. Okay.
Same with bile, right? Same with bile.
Sorry?
Same with bile peritonitis. You check the bilirubin of the effusion versus peripheral bilirubin.
I don't know if you can. Do you?
You can. I actually have a cat in hospital right now, and today's my day off. But yesterday, because has very severe cholangiohepatitis, the T-bill for that cat is 172.
Yeah.
And then yesterday I saw some free fluid, so I tapped it because I was like, oh, is it like ruptured? And the bilirubin, like, so the cat's peripheral bilirubin is 172, and of the fluid was 41. So I was like, doesn't look like it's ruptured yet.
Yes.
Would
Yeah,
aim for it,
interesting.
but not yet.
Yeah, that's a really good way to do it. And it's so logical. I'm sure we've done that before, but I forgot. So what mechanisms might we see bile peritonitis happening?
Gallbladder rupture.
Cholangiohepatitis. Yeah, gallbladder rupture, which would be secondary to either an obstruction or inflammation. What's probably the most common cause of bile peritonitis we see in dogs?
Your mucocil, I
I
think.
think so, yeah. And when you see mucocele with a bile peritonitis, is there free fluid everywhere?
No, it's just like usually local.
Good. Yeah. It's very inflamed, but actually the volume of fluid is very low, which is going to make it a little bit hard to get your sample and work out whether it's ruptured or not. But obviously, if you're seeing a mucocele, it's going to be a surgery with inflammation around it. It's going to be a surgical problem anyway. I once had a Labrador that came in, a 2-year-old Labrador, very, very healthy, and then all of a sudden was shocky with abdominal effusion, and we ultrasounded it, took a sample, and it had a bile peritonitis with a completely normal looking biliary system on ultrasound. And we went to surgery. I didn't go to surgery. I referred to surgery. And it had eaten a full meal, got the zoomies and run around the backyard, and the heavy stomach full of food had pulled the liver and torn one of the intralobar bile ducts off the collecting system, like the cystic duct and stuff. And so the liver and gallbladder looked completely normal. There was just this and the surgeon's just like, I can't find it, I can't find it, I can't find it. And then moving liver lobes and going, oh, that one's leaking.
Oh, crazy.
Dogs are amazing. Labradors are amazing.
Oh, zoomies for that dog.
I know, more zooms. No running after meals. That is the key.
So do you say with the mucocele, it's common to have a localized bile peritonitis without rupture?
Oh, so it's really interesting. So mucocele is essentially a rock in the gallbladder. So when it ruptures, there's no liquid oozing out.
Oh, okay, yeah.
Does that make sense? Yeah, or if there is, it's very low volume because does everybody, I'm going to talk to you about biliary anatomy because I had it wrong for so many years. So the biliary system is like a big tree so my forearms are I'm just going to do one hand. My forearms is the common bile duct outside of the liver. And then this is the cystic duct. And then there's all these branches of the tree that branch up into the liver, right? And the gallbladder is actually just a pouch off the side. So if you've got an obstruction or a blockage in the actual pouch off the side, it's not necessarily going to obstruct bile flow. And it's going to stop bile from flowing into the pouch if you've got a big stone in there. And there's kind of resistance to flow. So it's all just going to flow right down the bile duct and into the duodenum. So we don't actually get a huge amount of bile flowing into the gallbladder and then leaking out where it's actually ruptured. It's kind of all blocked up and obstructed. So you get these microscopic little amounts of bile leaking out, but it's more like if you look at a mucocele, the gallbladder wall or a mucocele under a microscope, the wall is just completely necrotic and there's essentially just a big gallstone sitting in the abdomen, just causing an inflammatory reaction and a little tiny bit of bile peritonitis.
So gallstone is a mucocele?
No, sorry.
But just as bad as each other?
No, actually. So gallstones we see incidentally quite commonly with no ill effects. Gallstones in dogs are caused by either excess cholesterol and cholesterol processing abnormality or actually a biliary infection. So if they get an ascending infection 4 years ago and somebody put them on antibiotics and it went away or they dealt with it themselves, they could still have a stone sitting in their gallbladder and have a completely normal functional biliary system. It's just too big to pass. And I remember once sitting with Josh's Alex in ultrasound saying the number of times I've seen biliary obstruction secondary to gallstones is like I could count on one hand, and I'm ultrasounding this dog, and there's like 5 gallstones in its common bile duct. I manifested that.
What have you done?
Yeah. Yes. So it's actually really rare for gallstones to cause clinical signs, and because we don't see, like, humans have much worse cholesterol processing problems, and gallstones cause big problems in them, and these like sore gallbladders, and they have this kind of pain associated with gallstones. We don't see that at all in dogs. It's most commonly an incidental finding. A mucocele is, we are so off topic, but never mind. Sorry. A mucocele is actually an abnormality of the gallbladder wall. So most of the time it's secondary to a metabolic problem, which causes increase in cholesterol. And then we get inflammation in the gallbladder wall and a mucinous response to that inflammation. When you look at an early mucocele, or the sort of step before a mucocele, is mucinous hyperplasia, and the gallbladder wall is thick and black because it's got so much more fluid in it, and it's quite often variable in like thickness. And then you might see some sludge in the gallbladder that actually looks, it's like a positive contrast relative to the dark wall of the gallbladder. And as long as you can demonstrate that that sludge is still moving, so what I do is roll the dogs over and check that it's gravity dependent, it's still liquid. It's not a mucocele if it's still liquid, but if it gets very hyperechoic and it doesn't move, then it's turned into a mucocele, and that's an indication for surgery. I've seen quite a few dogs with mucinous hyperplasia that we've put on Ursifol and we've ultrasounded them 3 months later, and it's reversed a lot of the changes. So it's definitely.
Sorry, what was the drug, Anne?
Ursodeoxycholic acid.
Oh, okay.
Ursifol. Yeah, I shouldn't use the drug name, but
The other thing for septic peritonitis I was going to mention, particularly now that people are travelling a lot and holidays coming up, a dog that's been in the Riverina or Canberra or points, areas like that, grass seed penetration.
Oh yeah, for sure. Yeah, and cats get penetrating wounds during fights and stuff as well, so that's a good point. So penetrating injury or migrating foreign material. Kebab sticks. So there might not be, like, I've seen a kebab stick in a dog's abdomen, not in the gastrointestinal tract at all anymore, and it's got like a really mild inflammatory response around it. It's pretty amazing. So it hasn't got like a gastrointestinal leakage, otherwise it'd be fully sick. It's just got this kebab stick and probably some low-grade sepsis. All right. We've got 3 minutes to cover the other topics. And really, I'm just going to tell you, weight gain, make sure it's increase in body condition rather than accumulation of ascites. And that's pretty much all I got out of that chapter. And really, I mean, we all know there's medication, so it's either going to be increased caloric intake or change in exercise ability or alterations in calorie utilization metabolically. So they're the sort of 3 things. So did the diet change? Is their activity level changing? Do they have orthopedic disease, which means they're not exercising as much? And what clinical condition do we see, endocrinopathy, do we see associated with a reduced food intake but weight gain?
Hypothyroidism.
Hypothyroidism. It's kind of the only cause of weight gain that's not linked to either increased calorie intake or decreased exercise. And then weight loss. What causes weight loss?
Oh, the main question is weight loss with appetite or without appetite?
Yes. Yeah. So it's either going to be decreased calorie intake, it's going to be decreased calorie absorption if you've got gastrointestinal disease, or it's going to be malutilization of the calories. What's the other word?
Maldigestion.
Malutilization. Sorry?
Maldigestion.
Yes, yeah, so decrease, I put that in the malabsorption, but it should be a separate category, maldigestion as well. So what's the most common endocrine example of malutilization?
Hypertension.
Say again.
I was going hypertension, hypothyroidism.
Yeah, exactly. And then one more.
Diabetes.
Great. Excellent. What's another cause of malutilization that's not endocrine?
Cachexia,
Mm-hmm.
cardiac and neoplastic cachexia.
Good. Excellent. So increased calorie requirement, essentially, due to disease.
Weight loss as well.
Yeah. Yeah. Anything else?
Cardiac cachexia.
You
Okay,
mentioned
yeah,
that.
Josh mentioned, yeah.
Oh, okay. Okay.
Yeah. So really find the underlying disease. Think about those processes. If they've come in for weight loss, there's one of those processes going on, or that, I mean, I took my dog into the local vet, and said she's lost so much weight. And we just moved into my in-laws' place, and my 2-year-old was feeding the dogs. And we did ultrasound, x-rays, bloods, looking for the cause of her weight loss. And the 2-year-old was spilling half the bickies on the way to the bowls. And the more dominant dog was eating 1.5 times what she'd normally eat. And the less dominant dog was eating half of her caloric requirement. So that's definitely, let's quiz them for management changes.
Outsourcing.
Yes, definitely. All right, we better wrap up. I can't remember what's next. Does anybody know? How do you grow weakness and restlessness? Excellent. All right, we'll see you on the 15th of December.
Thanks, guys.
See ya.
And what's happening over the Christmas period? Are you what ones are you missing and so on?
The 15th, the next one will actually be the last one until February.
Okay, so
Feb. Yeah.
none in January.
None in Jan. Yeah, you all get some time off. And
Cool.
So it'll still be the same cycle.
Party. Wear your Christmas hats next time.
Oh, of course.
Still the same cycle, like the
Same
fortnight.
cycle. Yeah, exactly. Yeah. So we're just going to stick with this.
Yep. Okay. Thanks, and
All right.
see you in a fortnight.
Bye.
Thank you, Anna. Goodbye.